The most common compression syndrome of the wrist and hand is carpal tunnel syndrome. This is a pathological condition that decreases the area within the carpal tunnel, resulting in compression on the median nerve and the tendons within the tunnel. This tunnel is very unyielding, and so we end up with an irritation of the synovial sheath covering these tendons. Looking at the anatomy of the carpal tunnel, the floor of the tunnel are your carpal bones. The ulnar border is the hook of the hamate and pisiform. The radial border is the scaphoid and trapezium, and the ceiling is that flexor retinaculum. Structures within the carpal tunnel include the flexor digitorum profundus, flexor digitorum superficialis, flexor pollicis longus, and the median nerve. The median nerve divides into both a motor and a digital sensory branch. The distal wrist crease marks the proximal edge of the tunnel. The mechanism of injury for carpal tunnel syndrome includes direct trauma, repetitive overuse, or anatomical anomalies. The primary cause is repetitive wrist extension and flexion with a force applied. Additionally, there may be contact pressure over the carpal tunnel, compression causing problems, the maintaining of a pinch grip with a flexed wrist, and vibratory tools. Typically, this is going to be in the dominant extremity. In athletes, this is going to occur in repetitive or continuous flexion extension activities, such as cycling, throwing sports, racket sports, archery, or gymnastics. A secondary cause for carpal tunnel syndrome is pregnancy because of the distal extremity edema that occurs with it, diabetes, or rheumatoid arthritis. Signs and symptoms include localized carpal tunnel edema, which is not superficial. In chronic situations, there may be thenar eminence atrophy. The person may complain of pain, tingling, and burning sensation in the hand, which may radiate into the forearm. This is obviously where the median nerve distribution is. It is oftentimes relieved by shaking out the hands. This is called a positive flick sign. The person may also have nocturnal pain and may have comorbidities. For example, they may have a decreased tendon glide through the carpal tunnel, which leads to a trigger finger, or they may have cervical neuropathy. The special tests that we will use include Phelan's test or reverse Phelan's test, the Tinel tap test over the median nerve. You may also see a wrist flexion and carpal compression test. The manual muscle test will be thumb abduction, but really what we're looking for is a weak grip and pinch strength. Neurovascularly, we will want to look at the median nerve distribution. There will be pain, numbness, or burning sensation felt only on the fingertips on the palmar aspect of the thumb, index, and middle finger. Diagnosis of carpal tunnel syndrome requires a differential diagnosis to rule out several different disorders, such as thoracic outlet syndrome, both vascular or neurological, brachial plexus neuropraxia, cervical injuries such as discogenic or stenosis, and the diagnosis is going to be through C-spine x-rays, MRIs, nerve conduction studies, myelograms, or ultrasound. Treatment will start as conservative with hand splinting or bracing. The person may also receive corticosteroid injections, and we will look at their work and play ergonomics. Neural glides may be employed, and if none of these work, a surgical release of the flexor retinaculum will occur.